Okay, welcome everybody. I am Lauren Gates, your host of this evening's second masterclass called Breaking Barriers, Busting Myths in Bruxism, TND, and Airway Health. We're featuring our expert panel and my dearest friends, Dr. Michael Gelb, Dr. Ben Miraglia, and Dr. Jerald Simmons. Welcome everybody. We're so thrilled to have you here.
Thanks, Lauren.
No, you're welcome. I just am so excited to have all of you guys together. There's so much information to share. And on behalf of myself and the panel, we'd like to extend a warm welcome to our attendees tonight. We have over 700 registered. That was a record for us. So thank you everyone for your commitment. I know a lot of people are going to have the recordings later. So if we're not catching you now and on your free time, we're happy to be with you and provide this information. So as long as you keep registering, we will keep showing up. So it's a nice validation of the interest in our airway health movement. Before we get started, I like to get to know our audience better. So I'm just going to go ahead and launch a poll here to see who we have with us tonight. Give everyone a moment. We just launched the poll. I know people are logging on, but I just like to see kind of a feel for who's joining us. We have 43%, 45% participating. I'll give everyone a chance to vote, to tell us all about yourself. Okay, so we have a nice mix here. A lot of dental, mostly dentists and hygienists. We're thrilled to share this information because you guys see these patients every single day. So we're so happy to bring you this information to break some myths and break barriers and bust some myths. So I just need to do a couple of housekeeping items before we get started. The views are the opinions of our speakers and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions. The following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. And the information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health providers regarding a medical or dental condition. Also, some housekeeping items here. To receive your CE certificate, you must be in attendance for the entire program. Zoom software tracks your attendance, so we did not need a code or a survey at the end. At the end of our presentation, we will hold a live digital raffle where one lucky attendee will receive a free virtual ticket to Airway Palooza in March. So the winner must be present to win. So we have such a great night ahead of us. I think we should just go ahead and kick it off. And Michael, I think you're going to kick it off. Let me go ahead and read your bio and you can start sharing your screen.
Alrighty.
And then we'll get to it. Okay. Dr. Michael Gelb is a highly rated author and speaker on TMJ, sleep apnea, sleep disorders, and chronic headache treatments. After graduating from Columbia University with a DDS degree, he received his MS degree at SUNY Buffalo in neuromuscular research. Dr. Gelb went on to become clinical professor at NYU, where he directed the TMJ and oral facial pain program. Dr. Gelb provides solutions for dentists to incorporate TMJ, airway, and sleep into their practice. He is also the co-founder of the Foundation of Airway Health and its Airway Summit. And Dr. Gelb is the co-author of GASP, Airway Health, The Hidden Path to Wellness, and maintains a private practice in New York City and White Plains. He has pioneered airway-centric medical and dental education, and also the Airvada appliance. The Gelb Center was founded over 30 years ago by Dr. Michael Gelb's father, Dr. Jerald Gelb, and since then, Dr. Michael has taken his father's findings to the next level through his airway-centric integrated therapy. Welcome. Share with us what you have tonight. Can't wait.
All right. And listen, I'm Lauren, and thank you, and thanks for promoting all the nonprofits. We're all here to raise awareness, whether it's the Foundation for Airway Health or Children Airway First Foundation or TARF, Airway Revolution Foundation. They're all great causes, and always love presenting with you and Ben, Jerry, and Airway Health Solutions. So let me see if I can get on there we go. So, you know, I tend to kick it off sometimes, and I talk about TMJ as being the prequel to airway and orthodontics, but a lot of people start off, and I always love looking at the face. And I think, you know, I hear when Ben looks at the face, but I love starting with the face. Tonight, I'm going to talk about the basics of TMJ and how that relates to airway. And then I think we're going to hear a bit about occlusion and teeth, and maybe a little bit about the way the foundation, as Ben says, and the way the jaws fit together. So that was my dad's outline back probably in the 70s of what he used to teach. And I still like to start with visualization of the face, looking at where the patients come from, how they grew up, were they mouth breathers, were they nasal breathers, are they vertical growers, did they grow horizontally? We then go into an examination after we do the medical history and history of present illness, palpation. I do a lot with cone beam, with imaging. Now we've moved to digital impressions. We still take a bite, although we do things digitally, and we include sleep testing, whether it's a polysomnogram, although today it's mostly home sleep testing. So, these graphics help explain what we see, and you see what's missing from these graphics. And this is really the way most orthodontics look at the teeth and they look at face. But what's missing is that when you look at the teeth, it's really in conjunction. In other words, I said to someone today, most orthodontists would take your teeth and put it on the tabletop. They would take the upper model, the lower model, but they would really pay no attention to the temporomandibular joint, and they would pay no attention to the airway. So you might say this is a fairly normal setup. The TMJ is fairly normal. There's a decent airway. But when the maxilla is back, when the foundation's small, when the mandible's trapped back, you see that you very often get a overloading of the joint. You can get disc displacement, and you can get narrowing of the airway, which can lead to sleep disordered breathing. As that comes forward, it gets better. But after you see someone like Ben Miraglia, and he's able to widen things transversely and make more room for the tongue, the TMJ's almost always happier, and the airway opens up. And so we're leading to an open airway. Now, when you have people like Dr. Simmons on, he may also talk tonight about non-anatomical factors, but I think we talk primarily here about anatomical factors, but and everyone in the world is now gaining a lot of interest in low muscle response, arousal threshold, loop gains, and things like that. So we've always looked whether the mandible's off laterally, and then very often what we see is in our patients coming in, we often see cants. We often see the jaw off to the side. And then, there's always, and I see this just all the time, every day. And we try to make it understandable to the people out there. And then this is kind of how I explain what happens. Of course, when you go to the dentist and they put paper in the mouth, they put articulating paper, what you're going to see in a case like this typically is the bite is hitting harder on the patient's left side. That would be your right, but the patient's left right here. And what does a dentist do? They equilibrate. What happens when they equilibrate? The bite gets even more overclosed, the pain gets worse, the loading increases. So you don't want to be equilibrating a case like this. And then with more age, we can get more loss of vertical dimension, which makes the airway worse. So a before and after, this was referred to me by Dr. Riasecco. It shows you the transition that you can get. And my secret always, as you know, and I'm willing, usually I tell you guys my secret, the secret is oxygen and restorative sleep. It's oxygen and restorative sleep. It's an old recipe. The doctor says to me, like Larry Rosenthal, Michael, fix the TMJ, fix the airway, give me the bite. Fix the TMJ. In other words, get rid of the clicking, get rid of the pain, get rid of the headache, get rid of the neck pain, get rid of the ear fullness, open up the airway, manage the sleep apnea, improve stage 3 sleep, improve REM sleep, and show me where should I restore the case. And this is where he restored the case. So I hope you like my accessorizing and my hair, but this is the type of results that we get. And I attribute a lot of the results that we get to what we're doing with sleep. We've learned that sleep is way more profound than what we can do with TMJ. And we work with sleep, we work with systemic inflammation, we work with endothelial dysfunction, oxidative stress, and sympathetic activation. Now, as we age, you can see the differences in the shapes of the face. I never knew this, but there is an aesthetic triangle. And you notice that with aging, we get a lowering, we get a lowering of that triangle. So we have jowls, we have loss of collagen, we have loss of muscle tone. And it's a falling, if you will, it's a falling of the face. That's why some people refer to a cosmetic procedure as a facelift. With aging, we seem to lose that lift that we have in the face. Well, I learned from my dad, and I've learned from a lot of my mentors that there's a way that we can reverse this aging process. You look at the pear, and you look as the pear gets dehydrated, the pear loses water, the pear loses hyaluronic acid, loses proteoglycans with age, loses the height of the face, loses the lips. And as we age, what happens with that loss of height, it closes the airway. Now, what's the chicken or what's the egg? Is the closure of the airway due to the loss of face height? What causes what? What's causing the aging? Is the sleep problem causing the inflammation, which is causing the aging? Can we reverse it? I'm going to tell you right now, I know you can reverse it. So that's why this is so interesting, because when we look at the face, how do I get a patient from there to there? Took me about 3 to 4 months. But we can get a patient from there to there. Now, the woman in the middle, that was all Michael Gelb and team. That's with a nighttime appliance and with a daytime appliance. My friend Tom Romo, who's a plastic surgeon who started the Little Babyface Foundation, he put in some fillers and did some Botox. But I would say the dental team here did about 90% of the work. And if you look at her eyes, she looks like a completely different woman to me. She's no longer tired. The inflammation is gone. Her eyes have opened up. She has lips. She has lower third face height. The masseters, which were swollen and hypertrophic, have come in. This is what she looks like in the cone beam. She's slanted up, canted to the left. You can see that she's lost lower third face height. Airway doesn't look bad. And she did have sleep apnea. TM joint is overloaded. The joints are too far back. They're compressed. Similar patient. Interior designer comes in, has had 2 rounds of ortho, fraction lesions. She's tired. She's in pain. 5 months later, she's got her hair done. She's got earrings on. She's got lips. We got rid of the nasolabial folds. We made that better. She looks more refreshed. Her eyes are not bloodshot. We've improved lower third face height, but what's more important, we've given her oxygen and we've given her restorative sleep, and she's very resilient, as most of my patients are. She's able to do this transition that you see here over about a 3 or 4 month period. And I think that's why I do what I do. That's the transformation that I'm looking for. So whether it's this patient that's referred by Lenny Cobran, who I work with in White Plains, who said, Michael, find the bite. She wants to get her teeth restored. But that's the kind of work we do. So the introduction to TMJ, and whether it's this model, it's a very similar type of approach. So she will only model now with my TMJ appliance in her mouth. You know, we talk about airway centric, but before that, you know, when everyone talks about TMJ and you have an introduction. It's thought now that TMJ is people follow the biopsychosocial model. So this is the latest one out of the latest edition of the guidelines from the AAOP. So the biological part is thought to be your genetics, inflammation, sensitization, and now people are starting to talk about glial. That should be glial activation. And glial activation is something that is associated with sleep apnea. I talk about it a lot when I talk about the prevention of Alzheimer's disease, but it also is involved with central sensitization, and it's involved with pain. Under psych and behavioral, sleep, diet, parafunction, anxiety, and tonight, we're doing a lot of talk about parafunction. The two things that are most related to parafunction, and I always love hearing Dr. Simmons on this. He's really, I'd say, the expert in the United States, but when you talk about parafunction, people talk about sleep apnea, other people talk about, alcohol use, and certainly certain medications, certain drugs can cause increased parafunction. But we talk about anxiety, stress, expectancy, catastrophizing, and then emotional trauma. And then there's social and environmental, which is your culture, your epigenetics.
This is how we looked like about 8,000 years ago. This is about 2,000 years ago. And coming up here is how we looked about 300 to 400 years ago. So you see how much skinnier and how much longer our faces have become. But by far, the biggest change happened in the last 400 years.
And that's why we're talking today
This
about...
woman represents the sort of facial growth that we had about 500 years ago. As the centuries pass, she starts representing where we are now.
And so for my friends out there that don't believe in any orthodontics or don't believe in any irreversible changes, if this is really true, which I certainly believe it's true, if we're dealing with a different foundation, if we're dealing with a different maxilla and different mandible, if we're dealing with increased mouth breathing today, increased tongue tie, then it kind of behooves us to permanently open the airway, grow the airway, and make the individual more adaptable for today's society, which means that they can sleep better, they can breathe better, and sleep better.
This woman represents...
And I could play that over and over again.
What you're seeing right now is what has happened to the airways in humans. This is why we have sleep apnea. This is why we have crooked teeth. This is why we can't breathe right.
And I think I'll let Ben go into that later and maybe go deeper into that. But this is Lieberman's work. You can see the condyle is really out of the fossa, but we're dealing today with the small retracted face. As our brains got bigger, our mid-face retracted, and there's no comparison with early Homo sapien or with Neanderthal man. And certainly Kevin Boyd has done a lot to talk about Darwinian medicine and his work with the Morton collection. He's really forwarded the thinking, and he's really the one, along with Ben, that's got me to measure the distance between first molar and first molar and determine whether there is enough room in the mouth for the tongue. And here we can see the hunter-gatherer jaws, the thick, broad masseter. And you can see the direction of growth is forward. Whereas today, our direction of growth is down and back. That's most of us today, a lot of us are mouth breathers. We're vertical growers. And the maxilla has been pulled back along with the mandible. And like my friend Bill Hang says, most of us are bimaxillary retrusive. That is, the maxilla is retrusive and the mandible. And I would say that's true with just about all the patients I see today are bimaxillary retrusive. And Ben will talk about that, that just there's not enough room in the foundation of the bone, so the teeth are crowded. The orthodontist still says in many cases, in the orthodontic programs, they're still teaching bicuspid extractions, which tends to make even less room for the tongue and for the airway. And so we know that in the human, the epiglottis descends at 6 months of age. There's a floating hyoid, not a strutted hyoid. We have a flexible pharynx so we can speak better, upright posture, large brain, flat face. I drew this because these are kind of the different faces that I see. And I talk, and I was just speaking in Leeds in England, and the oral surgeon had the same thing. We're dealing with the small house. We're dealing with the small house. That is, if the maxilla is narrow, the nose is narrowed. And whether it's the maxilla or the mandible that's back, whether it's the maxilla and the mandible that's back, and sometimes the chin keeps growing. But this is typically the case. You will see in some of the examples what we're talking about. And typically, with TMJ, we're dealing with women, their estrogen receptors in the TM joints, first found in female baboons. And so this affects swelling, it affects inflammatory cytokine release, and it increases pain. The area gets sensitized, and you see that after puberty in high school and college girls, and then you see it around perimenopause at age 49, 50, and 51. But what brings the patient in is clenching, which is one of the subjects tonight, along with chronic jaw pain, chronic neck pain, tooth sensitivity, chipping teeth, breaking teeth, headaches, neck pain, ear symptoms. 1/3 of my practice, like my father before me, is also tinnitus, ear fullness, and ear pain. So we know the TMJ, just a little bit of anatomy. It's a hinge joint and a gliding joint. One compartment, translation on the top, rotation on the bottom. It's a synovial joint. The fibrocartilage is here in the darker gray. It's along the this forward side of the fossa. The fibrocartilage is one from the top to the front of the condyle. So Dawson finally figured out, Harold Gelb and Bill Farrer were there a long time ago, but Dawson figured out between 82 and 85 that centric relation should be in that position. This is, what textbooks would agree is the ideal position in the joint. That is the biconcave disc there in light blue. There's a healthy cortical bone. And then with opening the jaw, it translates, it goes down with activation of the lateral pterygoid, as I said, both fibrocartilaginous. And then there are the muscles that guide the movements, the closing muscles, primarily in masseter temporalis along with medial pterygoid. Again, the innervated tissue is right here. It's in the back of the joint. We don't want the condyle to be articulating. We want that space to be open, approximately 6 millimeters in the back of the joint. We know the masseter muscle commonly involved and can be overloaded and overused, but refers pain into the teeth. It can also refer pain into the ear. Temporalis muscle primarily refers pain to the upper teeth, can also be above the eyebrow. Temporal tendon, which I just saw today, we see people that have plantar fasciitis, patella tendinitis, lateral epicondylitis. These people have what is known as a seronegative arthritis or an inflammatory arthritis, and these people can present with the pain right around the coronoid. This is different than muscle pain, myofascial pain. This is different than TMJ pain. This is what we call tendon insertion pain, and it's common in a certain sect of the population that also is prone to things like tennis elbow and things like plantar fasciitis. The sternocleidomastoid muscle is one muscle that can refer pain across the midline. This is the one, the clavicular division, that can mimic dizziness. And it also can refer pain to the frontal area of the forehead, but it also refers pain into the ear. Trapezius classically refers pain up to the temporal region. If someone's complaining of a vertex headache, it sometimes comes from a muscle like the splenius capitis. Treatable by trigger point injections, physical therapy, and Botox. And then as we get more into a forward head position, working with the iPhones, the telephones, with iPads, with computers, we can get that pain going across over the top of the head into the frontal area. Now, one thing that we commonly see, and we take cone beam on every patient, we see a lot of arthritis developing in the temporomandibular joint. And when you get arthritis and the jaw moves back, this can lead to closure of the airway. So we're looking for a normal joint space, but very often we see a loss of joint space like you might see in the knee or any other joint in the body. And this is typically what I'll see in my patients. This is a arthritic joint. There's a anterior osteophyte. The joint is flattened. You can see some flattening in the articular eminence. Also in these cases, there's a subchondral cyst. And so this gets read by board certified radiologists. So typically you get some functional remodeling. The joint has a adaptive capacity. It has allostasis. It responds. But if the adaptive capacity is exceeded, that's when the host can have symptoms. And typically it's from either macro trauma, but more commonly it's micro trauma, it's bruxism, it's clenching, it's functional overloading. The joint dries out. There's hypoxia, like we see in, with sleep apnea, but there's a lack of oxygen. You get these reactive species. We get inflammatory cytokines. The joint dries out. You lose the proteoglycans. And before you know it, patient says, I have a clicking in my joint. I have a slip disc. Very common. And so most of the time we adapt well. And most of the time this goes away with Advil, NSAID, soft diet, moist heat. And that's what we tell all our patients, soft diet, moist heat. But when they come to see me, if the occlusal factors or there's trauma or there's something like COVID or there's emotional stress, someone's sick, someone's son is sick, you can exceed the adaptive capacity of the host. You can overload the system. And usually it's the muscle, either the muscle takes the brunt or the joint takes the brunt or the teeth take the brunt. Long term, you can get involvement of the central nervous system. You can get central sensitization. The glial system gets involved. You get descending inhibition, and it alters the hypothalamic pituitary adrenal axis, which, by the way, all these central mechanisms also get involved. And I'd love to hear Dr. Simmons on this, but they also get involved when you have sleep apnea, some of these same mechanisms. So is this happening because there's really a sleep problem, an airway problem? And that's my airway-centric philosophy. So I believe that as we age, I know that certainly women in menopause become sleep patients, but I also like going back to Jim Frickton and looking at these contributing factors, because if you don't deal with the behavioral factors, the social factors, the biological factors, the environmental factors, and certainly emotional factors play a role, and cognitive, the patient's not going to get better, particularly if they're perpetuating. So we always look at joint space, whether it's concentric or the Gelb 4-7 position. We know that dentistry, going back to B.B. McCullum in 1924, dentistry always was a rearmost, uppermost profession. It was a retrusive profession. And when Tweed came along in 1945, took over for Angle, he took out bicuspids, and it became even a more retrusive profession. Well, that means that we've been closing the airways for roughly 100 years. Now, thank God, Dawson came around. Now, Gelb and Farah were there in the 60s and the 70s. Finally, in 1982 or 85, Dawson said, look, I don't think we should be far back. I think the jaw belongs against the eminence. Frank Salenza Sr., and I'm friendly with Frank Jr. and with Vinny Salenza, he believed in a long centric. So these thoughts have been percolating. I think it's rather accepted now that the jaw should be up against the eminence. And certainly with any of us treating sleep apnea, we're preventing the jaw from dropping back at night. Again, these are some of the reasons why people get TMJ. We certainly would add mouth breathing to that today. We would add tongue position. Estrogen, as I said, plays a big role. My dad always said birth trauma, so I think I'm going to include that as well. Now, Lane Martin came up with a slide, and I love this slide because we're talking tonight about parafunction. And I believe, and I'd love to hear the other speakers, but when I see someone that has wear in their teeth, and I had a man in today and he had worn out, he had a reverse smile line. When we see someone who has wear like this, or we see someone who's coming protrusively, we think that they have an airway problem. When I see someone who has a crossbite like this, I know this patient is a mouth breather. I know this patient has a high, narrow vault, and they're going to have a narrowed nose. When I see abfraction lesions like this, I'm thinking airway problem. When I see a scalloped tongue, look, I could be into Chinese medicine and I can tell you about, other things about this patient, about their spleen and their liver. But this patient, the tongue is too big for the mouth. And are we going to cut the tongue? No, we don't cut the tongue. We make the mouth be bigger. When I see crowding in a child, I've listened to Ben Miraglia, and I know that the foundation is too small. So like you see this arrow here in the FedEx logo, the next time you see teeth like this, I want you to think airway problem and not think like a dentist. I want you to treat the airway problem first diagnose it, then treat it. And then the last thing you're going to do is treat the teeth. So we have disc displacement with reduction. We have disc displacement without reduction. We've always done a lot of three-dimensional repositioning over the years. We have something called the Mora or the Gelb appliance or the ACG. We still use a ton of daytime appliances. It's the most popular daytime appliance in the country. But I've popularized this concept along with Howie Hinden of airway centric. And that means that as the jaw comes forward, down and forward or forward, the main benefit you're getting is really by opening up the airway. And a lot of the healing that you're getting is probably because you're improving the depth of the sleep, restorative sleep, improving oxygen. So you're healing sleep fragmentation, improving sleep fragmentation, and improving oxygenation. We take the bite, and we go over this in our course, day-long course, which you're invited to take, about how to take the bite. But Ben, and we've been saying this for a long time, it's really the maxilla. That's the culprit. That's what's driving the equation. And this is kind of how we take the bite for the Gelb appliance. It's how we take the bite even for a sleep device. Again, we always want to open the airway. We never want to take a bite that's going to close the airway. I like to put the chin in the middle of the face. So we have a protocol to do that. And that's what gives us not only the aesthetics, but it's also what gives us and allows us to reduce inflammation in these patients. Now, typically, I would say 90% of the patients that are out there in the United States today, and we have a long way to go. I mean, we have 600 or 700 people with us tonight. I think it would be great if we had 20,000, Lauren, but this is what's still coming in on every patient. It's a night guard, and it's the way we've been taught in every dental school in the United States is to take a retruded bite, put the jaw back, it closes the airway, it makes TMJ worse, it puts them back into a B.B. McCullum position, a nathological position, and I call it a primitive night guard. Now, the literature says that it worsens snoring and sleep apnea in 50%. I think it worsens snoring and sleep apnea in 90% of the patients. It brings us to the need for the modern night guard, the Airvada. And that's the Airvada, and allows me to say that with the Airvada or with the healthy night guard, you'll wake up refreshed. You'll wake up in a better mood. No headache, no clicking, no jaw pain, no snoring, and open airway. That's our criteria. Now, when I do the Gelb appliance, it's a three-dimensional repositioning appliance. It helps stabilize the cervical spine. It opens the airway. It helps reduce bruxism. You wake up with better memory. You're decreasing inflammation. You're improving oxygenation. You wake up with improved focus and concentration. In kids, we're helping the prefrontal cortex develop. We're getting 50% of kids, as per Steve Sheldon, off of ADHD medications, and helping things like oppositional defiant disorder like Connor Deegan. The kids are less anxious, they're safe, they're not being choked, they wake up refreshed, they can focus, reflux gets better, we're decreasing negative pressure, and we have psychological well-being. The brain is being restored. The patient's not being choked 100, 200 times a night. Big difference. So this can be used in work, play, and sleep. It puts the condyle in a safer position. You can use a Gelb appliance during the day. The indications for a day appliance would be clicking and popping, daytime clenching, which a lot of us do in New York City area, fullness, tinnitus, ear pain, neck dysfunction, and imbalance. At night, if the symptoms are worse on awakening, we're going to use a night guard, the healthy night guard. If the patient's waking up locked, we're going to do a appliance that allows them to wake up unlocked. If they have joint pain, narrowed airways, we want to open the airway at night. And if the jaw shifts to the right, or it shifts to the left, or it shifts backwards, we're going to use the Airvada. Also, nighttime clenching. You could use a Gelb during the day or an Airvada at night, or you could use the lower part of the Airvada during the day. That's the kind of the way the Airvada is designed. That's the Gelb. And that's kind of what the Airvada looks like on top. So it has a ramp on it that prevents the jaw from dropping back. So this has just been a brief explanation about what we do, how we put it together. I've tried to explain how the TMJ relates to the airway. We've talked a little bit about clenching, and we're going to talk more tonight with the other speakers about clenching and about sleep, and then about maybe how to fix things orthodontically. Again, that's the upper component. I also use a prosomnus device at night. I can put a bump on that too if there's a Bruxer. That's FDA approved. The Airvada is going for FDA approval now. So I think TMD is usually the first sign of an airway disorder. And I found that most people that have a temporomandibular disorder also have an airway disorder. And there's no better place to learn about it than with Airway Health Solutions. So the next time that you see the FedEx logo, or the next time that you see occlusion like this, please consider diagnosing for an airway disorder before you put a device in the mouth. That's what we're recommending. This is my article on airway centric. And I said, airway trumps all. The teeth are the last thing we look at. We look at the TMJ and the airway first. We look at bruxism, we look at the cervical spine, we work a lot with physical therapists, we work with some chiropractors. And again, the American College of Prosthodontics has recommended that you should screen for sleep apnea prior to fabricating a night guard. If you don't, you might be subject to liability. If you make a guard that just opens up the vertical without protruding the mandible, you might be subject to liability. Once you've heard this, I think you can't go back and put a night guard in tomorrow that's going to close the airway. And thank you, Lauren, and thanks everyone out there.
Thank you so much. There's a question that perhaps you can answer while you have your slides there, or go back to them. Did they have nose jobs from the first pick to the second when you were showing those women?
That's Michael Gelb's nose job. There was no nose job, and those pictures were not doctored. They weren't touched up. For some reason, we're able to fix the cant somehow by, the bones, either cranial sacral, working with physical therapists, working with the orthodontist. But a lot of that is just with appliance therapy. I actually think that after they work with Ben, they're even better. Sometimes they're often better. And I get them pretty good, but once Ben opens up the space and gives the tongue more room, they don't need as much appliances, and they're really in much better shape after the ortho than when I get, but you can see there's a big transition just with appliance therapy.
Wonderful. Thank you so much. Okay, so we are going to go to Dr. Miraglia. I'll do a quick intro while you get your slides ready. Dr. Ben Miraglia is my partner in crime in Airway Health Solutions, and is also an experienced healthcare professional with a focus on dental medicine and orthodontics. He graduated from the SUNY at Buffalo School of Dental Medicine and has been practicing for 29 years in Mount Kisco, New York, with 20 years of interceptive orthodontic experience. Dr. Miraglia specializes in early childhood growth and development. He's a renowned lecturer, sharing his expertise nationally and internationally on topics such as sleep disordered breathing, clear aligner therapy, and craniofacial development. He is actively involved in the field and serves on the board of directors of the American Academy of Physiological Medicine and Dentistry. And additionally, he's a member of the President's Council of Northern Westchester Hospital in Mount Kisco, New York. Okay, why don't you take it away, Dr. Miraglia?
Okay, great. Hopefully I unmuted myself correctly.
You
Here we
did.
go.
You're all good.
I did it right. All right. Yeah. Thank you, Michael, and happy to be here talking with you and Jerry as well. What a group. So I'll do my part. Let's see how it goes. So we're going to meet people like this all the time. And these patients are referred to me from Michael. So I have the opportunity to collaborate with him because we're within about 30 minutes of each other. So he's really teeing these people up. So when he gets the patient and they have all their headache, TMD, facial pain, all the symptoms that they have, he has the opportunity to stabilize them. And you just saw how that happens. And once he has them stabilized, reduced symptoms, comfort level increased, all of a sudden the headaches are gone, recapture the disc, all the inflammation reduced. If you can get to a certain comfort level, then he refers them to me and I have the opportunity to offer some either orthopedic or orthodontic services to improve the positioning of the teeth and the bite so the patient might enjoy, another level of comfort. So we meet people like this all the time. And this gentleman is suffering with all kinds of, facial pain and headache type pain. And of course, he's got a bite that's less than acceptable. He does hit mostly in the anterior. He can't get his back teeth together. And of course, he has no comfortable place to rest, but he has a list of symptoms. So when he gets to me from Dr. Gelb, he's already been basically improved to a nice level, but then I get to move the teeth. Now, when we're taking a look at this patient who's trapped in a bite like this, any patient that is underdeveloped or narrow will have a trapped mandible. And if the mandible is trapped back, we're going to have more pressure. We're going to have an unhappy set of muscles, disc, condyle, the whole complex is going to be miserable. So we want to take that upper jaw and develop it so that the lower has freedom to come forward. Now, if you notice on the left side of the screen, he actually has all 16 upper teeth in there, but he is narrow. And even though all 16 teeth are there and he doesn't have any crowding, this is still an underdeveloped maxilla, and we would like to develop it. Now, on the right side of the screen is after about 18 months of arch development, we still have all 16 teeth. This is not an extraction. We're doing the opposite. We don't subtract, we add. So if he has no crowding and I have to open up the upper arch, the back teeth get wider and the front teeth go forward. And we do this until the lower jaw has a resting place with total comfort. So the goal is to have 100% symptom relief and total comfort. So if we open him up that much, all of a sudden I have room for extra teeth. So we'll make him, he has choices. We could do implant work. We could do a traditional bridge. But in this case, we chose a more economical version of restorative, which was bonded ceramic Maryland style bridge work. Prepless, the wings are there. We just, bond the teeth. The bond is very strong. These were bonded in 8 years ago. So now we're 8 years post-treatment and they're still there. Now the lower arch gets all the uprighting. We still have to have the lower follow the upper. So if the upper gets bigger, wider, and forward, the lower needs the wider. The forward will come from the release of being the, trapped back kind of thing. And Michael had alluded to it. So if you take a look at where we started, he started with an edge-to-edge bite. We developed about 6 millimeters of space on each side for an extra premolar. And in all of that development, he just gets to a normal overbite over jet. So the lower follows the anterior segment forward. The wider delivers the release, and the anterior movement allows that lower to fall into a position of just beautiful overbite over jet. And these are his own teeth with whitening gel. There's no veneers or crowns. The only extra teeth are the 2 premolars we made in the upper arch. So he has an extra premolar on each side. So he went from 32 to 34 teeth. This is an additive pathway. Michael had referenced retractive type of orthodontics. Well, in the past, you might have recognized this case being treated the other way, meaning someone would go ahead and take out the lower bicuspids. If you take out 2 lower bicuspids and you jam the teeth behind, you can fit everything underneath, but that's going backwards as opposed to an additive technique, which delivers everything wider and forward. Now, if we're going to have that big an effect on the maxilla and the mandible, we're going to see it in the face. So again, this is not a set of veneers or crowns. These are his own teeth with whitening gel. So going back to the full view inside, if you take a look in here, the only porcelain in his mouth are the extra premolars on the side, right behind the canines. So he goes from having that narrow, underdeveloped maxilla and mandible to fully wide positioning, and the release of the lower jaw coming forward will be more visible in the profile, which is right here for you. So a patient who had the edge-to-edge trapped lower jaw, underdeveloped maxilla, when we get the full width and forward movement of all of the maxilla and maxillary teeth, all of a sudden he gains the opportunity to have lip seal at rest. So those are important words because in the pre-treatment photograph, he can't get his lips together at rest. So he's basically a chronic mouth breather. The chronic mouth breathing affects the sleeping, affects the everything about a human being, and welcome to inflammation. So all of a sudden we get to a point where we've developed the upper enough that the lower can settle into a proper position, and he has lip seal at rest. So the way I like to refer to it, and Michael had alluded to it, where the maxilla is really, the culprit, I like to say the maxilla is the criminal and the mandible's the victim. So both jaws are underdeveloped, everything is narrow and back, but the maxilla really has another level, and it's the criminal compared to the mandible, which is the victim, because the narrow maxilla traps the lower jaw or mandible behind it. In the end, you have someone who walked in that had constant and chronic facial pain and tenderness in all kinds of groups of the muscles. And sure enough, he would describe it as even chewing food after a few cycles of chewing, his muscles would be tired. He'd have to pause and wait and then chew again. Speaking, if he spoke for extended periods of time, he would have to stop and rest and wait for it to catch up and then speak again. Now, of course, after treatment, he looks a whole lot different. Now, even though these photos might be 18 or 20 months apart, he looks younger. And he looks younger, like Michael was saying, the breathing and the sleeping. If you get the oxygen back and you breathe through your nose and you sleep better, all of a sudden you have a chance to heal. So now you have someone who is going on 8 years, asymptomatic, not a single headache or facial pain issue over the last 8 years. Another one, we meet a very nice principal of a parochial school, again, through Dr. Gelb. So he meets her. And again, the pre-treatment is to stabilize. So he's going to have a full diagnosis on this nice lady. From the photograph alone, you can see kind of the suffering that's going on here. She is not happy. She's not healthy. She's really struggling. And she has, just from the smile alone, a very narrow set of teeth. And narrow means trapped back. So we have the same deal here. Her symptoms, ear pain radiating up to her head, pain when chewing for as long as she can remember. She doesn't remember ever chewing food comfortably. Her jaw clicks and pops. She has ringing in the ears. And of course, she suffers from fatigue. And when Dr. Gelb gets her through the protocol, they realize with a sleep test, she has mild OSA. But this is where we end up with the bite. What he's going to do is take her to a point where she's stable enough to have the opportunity for orthodontic treatment. So he makes all the improvements that you've seen him show you. Stability, comfort, everything is fine, except this is where the teeth in the bite are. So without any appliances in, she keeps coming back to this, horrific place. So we would take her here. So now we're looking at, again, this could be like 1.5 years of growth. So we're going to grow everything, widen the arch, back teeth wider, front teeth forward. It's a very simple formula. Back teeth wider, front teeth forward. The lower's got to follow it. Back teeth wider, front teeth forward. But it leads to a whole different bite. And now all of a sudden we have this broad, wide, upright set of teeth that can land vertically to have, excellent occlusion. But the big difference isn't really what we can see here. It's, you almost have to pretend you're the tongue looking forward. If you're the tongue looking forward, well, on the left side of the screen, when the bite is all collapsed, the tongue would be looking at this narrow little chamber that it doesn't fit in. And if the tongue doesn't fit in that chamber, it's back. And if it's back, it basically obstructs the air. On the right side of the screen, where we have everything wide and in forward positioning, the tongue has an opportunity to be forward and high, which is where it belongs. And the tongue positioned high and forward allows the air to get behind it a whole lot better. On top of just the teeth moving and the width and the space being improved for the tongue, when the upper is wider and forward, the lower follows it. So even though we do a lot of forward movement, we have wider and forward, it doesn't increase and leave you with an excess overjet. The increase in overjet is absorbed by the lower jaw releasing forward. You still have beautiful contact of the front teeth. In the end, what happens, like Michael was describing, is healing. So the patient who has that mild OSA diagnosis, and then maybe might be listed in the overweight category, but hasn't reached the obese category yet by criteria. All of a sudden during treatment, as her lower jaw is positioned better, as her tongue achieves more room and space and is higher and forward, all of a sudden what happens is the breathing improves, so the sleeping improves. When the sleeping improves, there's a pretty good chance you could actually shut off the sympathetic nervous system at night. And if you can shut off the sympathetic nervous system and get back to the parasympathetic nervous system, the one that does the rest and digest, you could have a balancing of the body where all of a sudden the excess weight that's being stored for the fight or flight mechanisms is released. She no longer has to store all that. So what happens to a lot of patients where you do secure the better breathing and better sleeping is that without any change in their diet or exercise, they lose weight. So no change in their diet or exercise programs, and they lose the weight. So the weight peels off. So over time, we could learn that, this is 8 years later now, She's completely asymptomatic. She wears a clear retainer at night, splint-free, medication-free, improved sleep. She does not have OSA anymore, and she experienced a weight loss, which has been continuous through. She doesn't struggle with gain and loss and gain and loss. She's been very kind of stable for 8 years, and comfortable is the biggest one. We take a look at another one. So these are all similar patients in that they begin at Dr. Gelb's office, and once he is able to get them stabilized and comfortable enough, he makes a recommendation to say you could pursue some level of orthopedics or orthodontics. Go see if Dr. Ben can help you get a little bit better. And so we meet a nice lady like Jen. Again, the same type of bite where everything here is narrow and trapped back. And so we don't have any good balance in the occlusion. You can take the full history and you can see in some of the teeth, composites been added to teeth in certain places to try to give her more balance. She's had things adjusted. She's had things added. She's had things subtracted. She's had over the past this opportunity where any type of, whether it was additive or subtractive equilibration was being offered to try to make an improvement. Nothing really made a difference. So we're narrow with a little bit of crowding. You can see some of those onlay style composites put back there. Most of them don't really have much anatomy to them. None of them are really helping her land in the right place. And sure enough, she still has, you know, a horrific malocclusion of the underdeveloped jaw variety. And we need to get involved with the movement really to help this out. Her symptom list is significant. Facial pain, tension with headaches. It's a daily occurrence. Pain when chewing, the jaw clicking and popping, the TMJ pain, as she would describe. Some people will say they have TMJ. There's no relief. She's tried things over multiple, years in different specialties for no relief until she gets to Dr. Gelb. Once she gets to Michael and he gets her in the right appliances and has everything stabilized, and that comes with the full workup and the progress, like he was describing, within sometimes weeks or even months, the patient is totally resolved. The inflammation is gone. They feel terrific, but then it's time to have the opportunity to maybe move the teeth. So we get her then. And when I get her, it's the same formula, the back teeth wider and the front teeth forward. So back teeth wider, front teeth forward. We're going to open up that chamber for the tongue. And by getting the upper wider and forward, we're going to release that lower to follow it. So the lower back teeth have to upright. And of course, we'll do the back teeth wider, the front teeth forward. But in the end, we'll be landing here. Now, the big difference here is that on the right side of the screen, with her fully landing into all of this contact that she has 100% comfort. She doesn't have a single symptom anywhere. What you're noticing in certain places is missing tooth structure. We haven't done a single composite or a single equilibration. Nothing's been polished, nothing's been adjusted, nothing's been added, nothing's been subtracted. So the teeth themselves just have that original kind of position they came in. And we talked about at the beginning saying, hey, one day I'll make you onlays or crowns or whatever to fix those teeth. That was 9 years ago. So all of a sudden, 9 years later, she comes in every 6 months. We take a look. None of that composite that's there has worn any further, and no discomfort whatsoever. I still haven't been able to make a single restoration for her. And she bites and eats and chews everything without any discomfort, a total resolution of her symptoms. Here she is, much happier. So on the left side, very narrow smile. You can barely see any of the back teeth, open corridors. Now you've got all of the teeth moved out to where they belong in a beautiful wide arch. And all of a sudden you could have the same type of experience without a change in diet or exercise. The weight loss begins and the weight starts to peel off. And that adds another layer of help to the patient to be losing weight. So all of a sudden we're moving in the right direction. We meet other people. Sometimes they have even worse symptoms. So some come in and they're really in terrible shape. And this is one of them, again, through Dr. Gelb. The patient gets to him first. Not only is she suffering in every category, but it's been decades. It's decades of suffering, and no one has ever offered her any improvement in her TMJ or head and neck area until she finally found Dr. Gelb. So decades of suffering led to anxiety, because with going and trying to have this fixed, every single place she went to, she would always say in her history to Dr. Gelb or myself that anywhere she went, it got worse. No matter what they tried, it got worse, it got worse, it got worse. And one of the final things, she was able to describe to us was that you're the only two people she ever got to that made her better. Everybody else made her worse all along. So she's here. And of course, this is a terrible malocclusion, but of the underdeveloped variety. Everything is narrow. Everything is back. Everything is trapped. There's no tongue space in here. This is completely omega shaped, collapsed in. Her tongue doesn't fit in there. We're kind of forcing it in with the mirror to get a good picture of the teeth. But she has no good occlusion, no good resting place. The maxilla will be our criminal. The mandible will be our victim. And then the symptom list, all of them. She could describe for the last several decades how she's experienced just about everything in the TMJ head and neck category that you could describe. And it's on a daily basis with no relief, most often being worse after trying to attempt it. Well, she comes out of Dr. Gelb in a matter of just a few weeks to months with stability. And all of a sudden with the stability, he offers her the opportunity, maybe you should see Dr. Miraglia about moving the teeth and trying to improve your bite and making another level of improvement. So I get the patient already reduced in the inflammatory column already. If there were discs that are displaced, he recaptures them. If there's any type of serious problem, it's already been taken care of. I get to play with the teeth and the gum and the bone and the jaws. So we take her from here to here. So this is, again, widening and forward. The back teeth go wider, the front teeth go forward. The back teeth go wider, the front teeth. It's a broken record, but it is the simplest formula for comfort and health. So we just move the back teeth wider and the front teeth forward. So now we have a beautiful arch form at an appropriate arch width and a bigger chamber for the tongue. Well, the lower is going to follow that too. So instead of being collapsed in on the tongue, all of a sudden the lower teeth are all the way out and upright. So the tongue will have a bigger chamber. Now it's going to translate into this view. That's a very nice change to go from one side to the other. So now all of a sudden the tongue is looking at a mansion to live in instead of a tiny little chamber. But again, when the upper goes wider and forward, the lower follows it. So even though the top teeth and gum and bone, the whole dental-alveolar complex might be growing wider and forward, you don't necessarily have excess overjet because the overjet that you're creating by widening and developing the upper, the lower follows it. And when the lower follows it forward, it changes the position of the condyle, the disc, and the musculature. Basically, it resolves the retractedness that was trapped in this narrow bite for the last several decades for this nice lady. And all of a sudden, you could take a patient who was at the highest level of anxiety, who had never had any positive effect from anyone in the dental community, who would be really skeptical early on about doing this, to be totally comfortable, happy, healthy, symptom-free, and then be able to say that you two are the only two people who ever helped me in my life with my jaw pain. Then we get to another one. Now, there's a difference with this one. So I probably should have laid some general groundwork. I know Michael had touched on different specialties, and all of this is collaborative care. So it's not just Michael and me. All of it is collaborative care. There are definitely sleep studies involved. So there are sleep specialists involved. There's almost always myofunctional therapy involved. So the myofunctional therapist, major team player and team role here. Then the next one is going to be chiropractor, craniosacral, osteopath. All of these people play roles in how these people heal. It's not just, magic Michael and I, it's a whole team. So collaborative care. What you were looking at, what I was doing originally up to this point, technically was just clear aligners alone, but now I'll introduce a little more. We're going to use removable expanders prior to clear aligners. So the first bunch of cases had all of the collaborative care that, we do use, but my orthodontic technique involved clear aligners. At this point, this one patient we're going to share used fixed removable expanders first. So at about 19 years old, she ends up at Dr. Gelb's office, of course. She had gone to college, but the headaches were so much she couldn't take it. She left school, came back home, and then ended up at Dr. Gelb's office for her TMD problem. So here she is, you can see in the photograph, just struggling. And this is the bite she has, and it's terrible. This is where she is, and there's no way to have comfort with that type of bite. And of course, she's suffering with headaches that take her out of college and back home to have it fixed. So very narrow, very narrow. I'm a big fan of measuring across the arch, and we're going to learn in a little bit. The number here across is 27 millimeters. So when you measure from molar to molar, that transverse width, 27 millimeters is not appropriate for a 3-year-old. And at age 4, we really ought to be 30 millimeters between the A and J, the primary baby teeth. 30 millimeters at age 4 is the bare minimum to kind of grow into good teeth and good bite. All of that is Dr. Bogue's research, and it followed up with Dr. McNamara after that. But meanwhile, she's 27 at the beginning, super narrow. And then, of course, a horrific bite on both sides. None of this is right, of course. Now, her history. She had braces for 4 years, and her TMD pain and headaches began during the orthodontics. So at 12 years old, she got her braces on. Prior to 12, she didn't have a single symptom in the pain, TMD, or headache category. But as soon as the braces were put in, all of a sudden she starts having the TMD pain and headaches, and she suffers through the braces only to end up with the photos you saw, which is post-ortho. The jaw clicking and popping starts. The braces are removed about 15 years old. At 15 years old, they're removed because she can't take it anymore. The pain is too much, and nothing that they're doing is helping. Everything is really in a retractive model. So the lower jaw just keeps being trapped by that narrow upper jaw, and the pain just keeps increasing. Brackets and wires tend to be restrictive and or retractive in nature. So by 16, she visits Dr. Gelb and he works with her for a bit, stabilizes her, gets her comfortable. The appliances that he's using provide a lot of relief. And then all of a sudden, when the time is right, he could get her to me for treatment. And we did meet her at 19. So at 19, she has the opportunity to come to us. This is an upper, simple, removable Schwartz appliance. And we have her use this for about 9 months to get 5 millimeters of maxillary growth. Her upper arch is severely deficient compared to her lower. So we'll get a head start with this. Then we'll transition to clear aligners. This is just the first chunk of millimeters. So after the first 5, we go a little further, but about 7. So 27 to 34 is what the removable expander can give us. So now we'll have the maxillary growth. We'll have a change in the vault. The vault is no longer high and pressed up. It's starting to level or come down towards us. So as this whole complex rotates, you'll be able to breathe through your nose better. So you get an increase in the nasal cavity space. The tongue space is increasing. We've got 7 more millimeters for the tongue, and the area in there is a really nice dramatic change. Now, if we do then clear aligners, we can go farther. So all of a sudden we can go from the 27 to 34 in the removable expander, get our first 7 millimeters. But then when we switch over to clear aligners, we still want to keep going the same direction, wider and forward. So we tack on another 3. So 7 and 3, 10. This is a 10 millimeter change for the tongue space from 27 to 37. Now, 37 happens to be in a range where you could find good occlusion, because 35 to 39 millimeters is like a bare minimum range for occlusion for 28 teeth to fit in. If you're looking for 32, you need even more and a bigger foundation, of course, to fit in 32. But we're happy to get her to 37. Now, when we get to this point, if we can, let's see that next slide. There we go. The lower's got to follow it. So all of the lower teeth are uprighting also. So the top has a 10 millimeter change. The lower's got to go too. And all of a sudden, the tongue has a lot more space in there. So she does go through all of the things we mentioned. She has seen the myofunctional therapist. She has had a lingual frenum revision. All of these things apply because collaborative care really makes the biggest difference. She has the undersized 7 and 10. So again, a lot of whitening gel. The patients love the whitening gel, but the only 2 teeth that have some composite are 7 and 10. 7 is undersized, 10 is like a peg lateral. So when we put everything where it belongs, all of a sudden we need a little composite. We add it to 7 and 10. The rest is just her enamel with some whitening gel. But it makes a big difference in that human being, because all of a sudden what was a very narrow smile that you could barely see any of the back teeth and has just this open buccal corridors, has all of her teeth right where they belong in a full broad smile and total comfort. So with only some bonding on 7 and 10, we get to this point and you could see all of the facial tension on the left side. Pre-treatment, she's in all kinds of struggles. And of course, now we have this fully developed arch, tongue space, the lower released forward, and a patient that gets a little composite on 7 and 10, but no longer has any headaches. This, by the way, she's up to 6 years asymptomatic. We're going to adjust that date. 6 years post-treatment, hasn't had a single headache. Now, we're so confident about moving the teeth wider and forward and how this delivers. It's the first question we ask our patients when they come back for recall. It's been 6 months. We check their retainer. How you doing? Great. Have you had a headache in the last 6 months? Absolutely not. No. So the patients come back and tell us, I'm still comfortable. I can bite and eat and chew and talk and do all the things I like to do without having any trouble. Terrific. We'll see you in 6 months. And then we just let the years go by. So I tried to throw in a bunch of cases. Some of them are as many as 8 and 9 years post-treatment now. Very stable, very comfortable, and no symptoms. And a lot of it is really due to growing. You need to go wider and forward and give the tongue back that space to get the good breathing going. Get the upper wider and forward to release the lower. Let it come forward into position so you can have the muscles, condyle, and disc, and get your patient all that comfort back. So I'm so happy to be part of a collaborative team. I'm lucky to have 30-minute distance between myself and Michael to be able to help patients like this on a regular basis. It's been an absolute privilege, and thank you for your assistance and mentorship over the years, because I was not in this space originally. Michael's one of my early mentors to kind of guide me this way. And I couldn't sing the praises for him enough. And one of the people that I've learned along the way through Michael was Dr. Jerald Simmons, who you're about to hear from next. Also a tremendous mentor and fabulous gentleman, has wonderful information for you. Thank you for your attention.
Oh my goodness. Thank you so much. Let me start my video here. Thank you. That was incredible. And I am so excited that the three of you are on just to balance each other and add, and I can't wait for the panel discussion. But before I do a formal introduction to Dr. Simmons, he's also my band partner in the Pulmonauts. And, you know, it is, and any of you who are at Collaboration Cure, you saw us performing, but he is such a talent in the 12-string guitar that I just have to brag on him right now and share a little bit of what you may not realize with Dr. Jerry Simmons is he's an amazing musician, and he brings so much warmth and soul to his music that he didn't even know that I was listening to him when he played this song. I was walking down the stairs when we were rehearsing for the Pulmonauts that I literally did a 180 and turned around and just was so drawn to this beautiful music. He plays the 12-string guitar that it's so impressive, and I just had to share his talent. So let me make sure actually that I clicked on that sound part. I don't think I did. Hold on. I'm going to reshare this because.
Oh, funny.
Yeah, hold on. I have to do this. Okay, here we go. Hear it? Okay,
Well,
so that
Laura, next time you have to sing it.
next time, who knows what's going to happen next time, right? We have lots of plans in the background here, so we'll share that as that comes out. But I am really excited to have you on, and I will give you that formal introduction. So why don't you go ahead and share your screen while I do that, and then you'll be all set. Dr. Jerald Simmons is a triple board certified in neurology, epilepsy, and sleep medicine. He is a graduate of Ohio State University. He did his neurology residency at Washington University, sleep medicine fellowship at Stanford University, and epilepsy fellowship at University of California. He began his professional career as assistant professor of neurology at UCLA while co-directing the UCLA Sleep Disorders Center and directing the clinical neurophysiology lab at Olive View UCLA Medical Center. While there, he trained fellows, taught residents, and medical students. In 1999, he was recruited to the Houston area to the Sadler Clinic, where he established his sleep disorders practices and continued to conduct clinical research. In 2006, he founded and continues to direct Comprehensive Sleep Medicine Associates, providing clinical services to patients from infants to elderly. Education continues to be an important aspect of his career, having trained medical students, residents, and fellows in sleep medicine. In 2004, he established a Sleep Education Consortium, a 501c3 nonprofit organization that holds continuing education conferences with a mission to enhance the knowledge of sleep care professions on disorders. His new areas of focus include the assessment and management of individuals suffering from head injuries. He's leading up an effort that will hopefully provide new improved aspects to care of these patients. And you also have some research that was just, you got some grants, right, in the research. Why don't you tell us a little bit about that as well?
It has to do with pregnant women, monitoring sleep in women that are pregnant and seeing if we can identify the onset of sleep apnea, which would then allow us to intervene. It has to do with remote patient monitoring. So, well, thank you. There's a lot there. Also research on bruxism, things that were mentioned. I'm not, I guess you searched some archives somewhere to find some of that bio, but yes. So thank you very much. I'm flattered and humored by the inclusion of my guitar passion.
Of course, of course. Okay, so why don't you take it away and tell us about the aspect from your point of view?
Okay, well, so I think a distinction that's important to point out here is, I'm a neurologist. I'm a physician and a neurologist, and our audience tonight are dentists or people in the dental field, dental professionals, and that's not new for me. I've been talking and teaching and influencing dentists for 30 years now. But when you look at sleep apnea and some of the chronic diseases that exist, such as hypertension and diabetes, it relates to sleep apnea, and this is making more and more press, if you will, and it's being recognized more that sleep apnea can be behind other kinds of conditions. But from the physician standpoint, they don't really get it. Everyone talks about sleep apnea and everyone talks about oxygen, but really oxygen's not the cornerstone. It is part of the spectrum of the problem, and you're going to get a chance to get a better appreciation of that. But it's the airway, okay? And it has to do with the mandible and the tongue, the things we're talking about tonight. And the airway is a dynamic process. It's a dynamic part of the anatomy. The airway changes. There's a process that's fluctuating throughout the day and throughout the night. And that's the motor tone, the muscle, the neuromuscular function of what's going on in the upper airway will change the upper airway dynamics. So, I'm going to only have enough time to really touch on a lot of different aspects of this topic. And at the end, I'm going to tell you about some other educational events that you can go to learn much more of this information. Lauren had mentioned about the nonprofit I started 20 years ago, the Sleep Education Consortium, and we do an annual conference. I'll give you some information at the end. We're going into our 20th year of doing the conference, and it's for dentists and physicians at the same time. They're sitting there learning together. And I'm trying to enhance collaboration, because really that's what it comes down to. Because as a sleep physician, I need dentists to collaborate with, because there's certain aspects of what these patients need that I can't provide. And there's likewise, as a dentist, you can't do it all. There are dentists that try to be sleep specialists. And if you try to be a sleep specialist as a dentist, you're going to be and you try to do it all on your own, you're going to get a little sliver of what's out there, and you may probably mismanage a lot of patients, because a dentist is right there at the mouth looking at patients. So the dentist is seeing so much of this pathology, but you need a team to really effectively manage these patients. So the airway is a big problem. And the topic tonight is sleep bruxism, or bruxism in general, and then sleep bruxism. Okay, well, I'm going to give you some information, maybe some insight. If you're new to this, and if you're coming to this lecture tonight, and you really haven't been very aware of airway, then this will be an eye-opening phenomena for you. But for those of you that are already aware of this, some of this may be review, but some of this may be on the cutting edge and extend your existing knowledge. But when you talk about bruxism, what's the definition of bruxism? People typically think it's grinding of teeth, but really clenching is part of the definition of bruxism. So it's not just grinding, it's also the clenching process is now part of the definition of bruxism. Okay, so what are some of the causes? Well, malocclusion, okay, could be stress, could be nocturnal seizures. It's rare, but if someone's having a seizure in their sleep, they're going to grind and clench, and they can fracture teeth. It could be from arousals that are triggered as part of a muscle phenomena, a rhythmic masticatory muscle activity that could be occurring as part of an arousal, right? But I'm going to show you tonight, I'm going to go over another aspect of this phenomenon of bruxism, where it's a compromise. It's actually, bruxism is taking a compromised airway, and that's prone towards obstruction, and the bruxing process can help prevent the obstruction. All right. So a cause would be a narrow airway. So why is a narrow airway causing bruxism? And I'm going to give you some information that's out there that would help support this concept. Okay. So as a neurologist, I'm looking at teeth, right? Well, I've been doing that for years, but there's literature that's coming out that's talking about looking at tooth wear as a sign of obstructive sleep apnea. So, you know, this is an article that came out in 2015, and they are showing that that there is a wearing of the enamel and other signs of changes in the teeth that are associated with associated with sleep apnea. So I encourage sleep physicians, and as if you're a dentist and you're trying to reach out to your sleep physician, find this article, print it out, and give it to them. It's going to come. This is from the medical literature, right? So this is medical literature talking about teeth wear as a sign of sleep apnea, and that's just helping to bridge the gap, if you will. But between these disciplines. But you could see it's not just the wearing of the teeth, even abfractions are going to be a sign of sleep of bruxism, and also tori will be another manifestation of what can occur when someone's bruxing from the extra forces that are going to be exerted on the tissue and on the bony structures. So you're going to get a variety of different changes that can take place. All right, so if you're trying to say what literature is out there that's going to help support this concept, well, let's just talk about something simple that we're all sort of familiar with, and that's children that will have enlarged tonsils and adenoids. Well, there are studies that show that that there's a high incidence of sleep bruxism occurring in children that have enlarged tonsils and adenoids. And then if you look at the occurrence of bruxism following the removal of their tonsils and adenoidal tissue, there's a drastic reduction. So in this one study, they went from 45% of the children having sleep bruxism down to 11.8% after taking out the soft tissue. All right. So if this was due to occlusion, their occlusion didn't change. What changed was an improvement in their airway obstruction. This is not an isolated study. There are a number of studies. Here's another one, same finding, where in this study, they found 25.7% prior to surgery, went down to 7.1%. So here, by taking out tonsils and adenoids, you're improving the clenching bruxing process. And again, it couldn't be because you've changed the occlusion, because the occlusion didn't change. So why is there a change? So to understand this, we have to go back to the basic principles of what's behind obstructive breathing. Okay. So when a person's breathing, air rushes through the nose into the back of the throat. And as air flows through the back of the throat, it creates a vacuum or a negative pressure. And if the space is going to be more narrow, there's a stronger negative pressure. It's called the Bernoulli effect. Let me give you an example of the Bernoulli effect that you can relate to. It would be in the shower. So you know in the shower, when the water flows, the shower curtain can pull in towards the water. So why is the curtain pulling towards the water? It's doing that from the vacuum that's created from the flow. So whenever you have any kind of flow through any kind of space, you're going to get this negative pressure. If you have the same amount of flow through a smaller space, you get a stronger negative pressure. If you have the same amount of flow through a larger space, there's less negative pressure. That's why the new shower curtains bow outward to open up the space so there's less of a vacuum, and it's going to decrease the likelihood of the curtain pulling in towards the water. Okay, so when you have the air flowing through the back of the throat, you're going to get negative pressure. But as the muscles relax and the jaw falls back, the base of the tongue is falling further back, the walls of the throat are relaxing and being pulled in. There's a stronger negative pressure, and that negative pressure can start pulling in on the soft tissue, causing vibration. And that vibration is snoring. So snoring alone is a result of negative pressure in the back of the airway. All right. So when someone snores, you know they have obstruction, airway obstruction. The question is, how clinically significant is it? Well, it depends. If you have a lot of tissue, you're going to start snoring at a lower degree of negative pressure. If you have less tissue, it may take a higher degree of negative pressure before you start snoring. But the snoring is a result of increased negative pressure. And then at a certain point, the vacuum is so strong that the airway can completely collapse. At that point, a person's asleep, they're trying to breathe, but they can't. And the brain recognizes the person's not breathing. There'll be a brief arousal, or what we call, an awakening or a brief arousal. The airway then opens up and breathing's reestablished. Okay, that's the tip of the iceberg. That's the most extreme manifestation of the condition. It's where the airway completely collapses. I'm going to express to you briefly where you don't have to have obstruction to that degree in order for it to be clinically significant. Okay, but that's what most people think of sleep apnea is when the airway completely blocks. What you also need to know, though, is that the negative pressure that's in the upper airway disseminates into your whole chest cavity. So right now, while you're sitting here listening to this webinar, you're probably pulling to about -2 centimeters of water pressure. If you're a larger individual, maybe you're pulling to -8 or maybe even -10 centimeters of water pressure. When you fall asleep and the muscles relax, the airway becomes more narrow, and there'll be a slight increase in that negative pressure, very slight, and it may not be of any clinical significance. But as you start having more degree of obstruction, there'll be greater degrees of negative pressure. And in some individuals, there can be instances where they're pulling up to -50 centimeters of water pressure or even more. Well, I don't have time to go into all the ramifications of that, but I'll just go to throw out there right now that your heart is sitting there in your chest. And we know that the negative pressure can influence cardiac function and over time causes heart disease. That negative pressure can cause gastric juices to get sucked up into the esophagus, causing GERD, or causing reflux, heartburn. And it could even go all the way up, the reflux can go all the way up here to start causing erosion of the enamel. So the negative pressure is a real big problem, okay? So again, you've got the normal airway, and then when it starts to relax, and if the mandible falls back, and if you've got a compromised mandible, if your airway is smaller, your jaw is smaller, your jaw sits further back, which means the tongue sits further back. If you've got a narrow nasal passages, that means you're going to have more negative pressure just normally at baseline through your nasal respiration, and that's going to suck the tissue back, and it's going to help cause retraction of the mandible. But then you start getting vibration of tissue, and you can lead to complete collapse. So what can happen here is you can start getting tongue thrusting. Children will tongue thrust as a result of airway obstruction. And then that's going to start causing other changes in their airway, in their bite. Okay. And then you might start sucking their thumb. They may sleep better by sucking their thumb because it's helping to bring their tongue forward. And there's all, we touched a little bit earlier. Michael talked about some of the phenomena that's occurred where that over time we've now developed smaller airways for a variety of reasons through epigenetics. And we're not working our mandibles, softer foods. We're not maybe breastfeeding as much and more bottle feeding. So our airways are getting compromised and smaller. And then some of the behaviors that we do compromise our airway even further. What's important to know is that the main joint of the airway is your temporomandibular joint. And as your jaw changes its position, the airway dynamics change. And so when you're in an occlusive relation of your TMJ, your airway is different than when you're in a centric relation of your TMJ, especially if you're in the most retruded centric relation of your TMJ. Now, if you were to measure the muscle activity of your tongue, right, by, let's say, doing a EMG, electromyographic study, by putting let's say a little electrode on your tongue. Now, this was done experimentally, and you measured the muscle activity of your tongue, and you then increased the amount of negative pressure that you had to develop in your airway. So how would you do that? You'd start breathing through a tube, and then if you make the tube smaller, you now have to get the same amount of air through a smaller tube, so there's more of a vacuum. So by doing that, it's been shown that there's increased muscle activity of the tongue. All right. So I'm going to go over this again in a second, but repetition is important. Okay. So what's been shown is that this is a normal reflex that occurs that when you have more negative pressure in the upper airway, there's going to be increased muscle tone of your upper airway. This reflex gets blunted by certain types of events, such as alcohol will blunt this reflex. Certain medications, painkillers, muscle relaxants, it will blunt this reflex. Sleep deprivation itself will blunt the magnitude of this reflex. So if you're more sleep deprived because you're blunting this normal reflexive response that's supposed to occur when you have more negative pressure. Snoring is worse in people when they're sleep deprived, right? When you start taking snoring histories, you'll find this out. Okay, in REM sleep, your muscles are actively being paralyzed when you're in REM sleep. And we don't have time to go into all that, but that will blunt this reflex. So when you look at the upper motor, you look at the brainstem and you look at what's controlling the muscles of the tongue and of the pharynx. And the main area is the hypoglossal motor nucleus, right? And there's different things that are influencing the hypoglossal motor nucleus. Whether you're awake or asleep is going to have an influence. Then you've got rhythmic generators in other parts of the brainstem that are pacing your respiration. So you basically, you could be comatose and you're going to maintain your breathing if your brainstem is functioning. And that rhythmic respiration is occurring from these oscillating neurons that are setting impulses to the hypoglossal motor nucleus. But you also have this negative pressure reflex circuit. And this is the part to really elaborate our discussion on, and I'm going to come to this in further part here in a minute, but this is a circuitry that will change the muscle tone of your upper airway, and it's based on how much negative pressure there is in the upper airway. But then what happens is that the hypoglossal motor nucleus has descending output to control the muscle tone of not just your genioglossus muscle, but of other muscles of the upper airway. Now, there is a trigeminal motor nucleus also in the brainstem that controls your masseter and your pterygoid muscles. It seems to respond to the same influences, but it's not been as well mapped out, but it has a similar overlap. So I'm putting it here right next to that, and we're going to think of these two regions similarly. It's the hypoglossal motor nucleus and the trigeminal sleep, the rhythmic generators, and this negative pressure reflex circuit. Okay, so all right, so there's an interesting scenario that we're going to talk about here. I'm going to lead this out all towards a study that was done. That was really, to me, sort of a groundbreaking study. So again, when you breathe, air rushes to the back of the throat, and as it goes through the back of your throat, you get the negative pressure, okay? So there was a study done on people with sleep apnea that had a tracheostomy, that they had tracheostomies done. So the tracheostomy, that is where, it's going to have a little hole that's going to allow them to breathe, and it's going to go right into their trachea, right? Now, by breathing through this trach, they're bypassing the upper airway, all right? And I'm going to explain this part of this graphic here in just a minute. So these individuals had tracheostomies. So they're breathing through the tube, which means as they're breathing, air is not flowing through their upper airway. Now, during the study, they recorded the EMG of their tongue, and they also had pressure sensors in the back of the throat and in the nasal passages. And you could see here, whenever there was a breath, there was a slight increase in muscle tone, and that is from that oscillatory circuitry sending impulses to the hypoglossal motor nucleus, and you get a little bit of muscle tone. But they're not breathing through their upper airway; they're breathing through here. All right. So then they plugged the trach. So by plugging the trach, the individuals now had to breathe through their upper airway, and air is flowing through their upper airway. All right. And as the air was flowing through here, there was more negative pressure now that was being picked up in the nasal passages and in the hypopharynx. And right here, this tracing right here is showing you the flow of air. So if I go back, going back here, there's no flow of air, and here there is flow of air. But look at right here, that EMG on the tongue. With those oscillatory impulses, they're magnified, they're increased, all right? there's a higher degree of EMG activity occurring here because of the negative pressure that's occurring in the back of the airway. So here's when the trach is open. So when the trach is open, there's no flow in the upper airway, and there's just a slight burst of muscle activity. You plug the trach, and there's more negative pressure now, and as a result, there's more muscle activity. So this is a great example of showing that there's increased muscle activity occurring in the tongue from negative pressure in a human while they're breathing. Okay. And we're able to demonstrate that by using instances where someone has a trach and they're bypassing their upper airway. All right. So what about the masseter? Okay. Is the masseter a respiratory muscle? What studies have been done to show that the masseter has any kind of responsiveness that's even similar to what we see here in the tongue? Well, there was a study done a number of years ago by Howell and Surratt, where they basically had people breathing through a tube and they measured masseter muscle activity. So they were breathing through it, well, not a tube like this. Okay, sorry, a tube like this. And they had the ability to adjust how much negative pressure the person had to exert in order to get flow. All right. And then they measure the muscles of the upper airway, and they changed the settings in this to where first centimeters of water pressure, then they change it to -20, -30, all the way up to -60 centimeters of water pressure. And they saw that there was a increase in masseter muscle activity that went along with the changes in the negative pressure that was required in order to breathe. But this wasn't true just for the masseter. It was for the ali nasi muscles, for the genohyoid, myohyoid, genoglossus, which we've already talked about. And so basically there seemed to be a larger muscle response that was taking place as a result of the negative pressure that had to be exerted in order to maintain respiration. So they concluded that the masseter are actively functioning like respiratory muscles, because it's typically the masseter is not considered a respiratory muscle, but here it seems like it's responding like a respiratory muscle, and that it's working in response to the resistive load that's placed in the upper airway. Okay. So I recognized many years ago that when I had patients that had sleep bruxism and I treated their sleep apnea, their bruxism was improving. I would put patients on CPAP and the bruxing would resolve if I got the pressure set correctly. And I remember telling this to an oral-facial pain specialist, Dr. Ron Preen, and he was blown away by it. His whole career was focused on oral-facial pain. And so he challenged me and sent me more and more sleep bruxing patients that had TMD, and they were smaller individuals, a lot of times women with not obese, small mandibles, high arch palates, chronically fatigued. I'd seen patients like this before, but he started sending me more of them because that's what his clinic population consisted of. And so when I did their sleep studies, I added extra parameters to be able to measure this more subtle degree of obstructive respiration that I really don't have much time to go into right now, but we do use something called the PES, where we can measure the negative pressure in the airway. But what we found is that that basically in the sleep apnea population, about 25% have sleep bruxism, and that if individuals were treated with CPAP and they were compliant with their CPAP, that the majority of them that were compliant had drastic improvement in their sleep bruxism. And this was so impactful on his practice that he realized that most of his patients that had sleep bruxism and had TMD actually had sleep-related breathing disturbances. And we started tabulating this and presenting this at conferences. This goes back to 2008. And it's funny because I was contacted by someone who participates in something called Dental Town. I'm sure a lot of you, the dentists, know dental. I didn't know what it was. And there was all this debate going on about what I was presenting. And there were a lot of people that thought I was nuts. And I got on there and started to, go back and forth and express things. And some people just didn't want to listen. It's like they wanted to put their head in the sand and say, make it go away. But some of these individuals, it's funny that years later, they're now dental sleep specialists. They're oral facial pain dental sleep specialists. And Ron Preen had done that also. He'd gone on to become a dental sleep specialist, and actually he became the president of the American Academy of Dental Sleep Medicine's board exam, and held that position for 7 years. So, but clearly there's this overlap, and now it seems it's almost like it's common knowledge that yes, if you have sleep bruxism, it's probably an airway problem. But it wasn't so long ago that people were challenging me and saying this isn't true. But on our sleep studies now, we measure the external muscles of mastication on all of our in-lab sleep studies to characterize this better, and we've done a number of different studies. I don't really have time to go into this in great detail, but just to show that there is more negative pressure when the bruxing breaks down. So here there's less muscle tone, increased negative pressure. Here there's more muscle tone, less negative pressure. So this is sort of showing in a stepwise fashion as the person is demonstrating more bruxing. This right here, which is this parameter is measuring the negative pressure of the airway, and we can see less as there's more bruxism. So, but I want to propose to you that CPAP, which stands for continuous positive airway pressure, which is only one treatment for obstructive sleep apnea, but it's considered sort of the gold standard, and it's what the medical field has pretty much embraced. Although I treat patients with a whole variety of different treatment methods, and a lot of times with appliances as well. But I propose now that CPAP can be a treatment of sleep bruxism, and we've seen it many, many times. But if you're going to go down this pathway and you're going to open up this can of worms and you're going to start, going down this rabbit hole, if you will, and you're going to start dealing with sleep, you have to know that there's more than one way to score a sleep study. All right. There's two different rules for scoring what we call hypopneas. So apneas are the complete blockage of the airway. Hypopnea is a much bigger category. That's when there's partial blockage. So the question is, at what point of this partial blockage is it clinically significant? Well, I'm just going to tell you that the old rule was that you had to have an oxygen drop of 4% in order to tabulate a hypopnea. All right. That's ridiculous. My entire professional life, I've never held to that concept, because you don't have to drop your oxygen at all. You can have 0 drop in your oxygen, but if you have a partial reduction of airflow, or let's go one step further, if you have increased effort of breathing, and the increased effort alone triggers an arousal, then it's clinically significant. So there's a score 1A and 1B. The 1B is the 4% rule, where you have dropped your oxygen by 4%, and there's nothing about arousal in that rule. The 1A rule is a newer rule, and it says you only have to have a 3% oxygen drop, or I say or, meaning you don't have to have any drop, or you have to have an arousal in your sleep, as measured by EEG, for example. So it's clear that that the respiratory events can be in a spectrum. Okay, the problem is Medicare does not recognize Rule 1A. It only recognizes Rule 1B. And this scoring criteria, this came out in 2013. And a lot of physicians are naive. I just got a call over the weekend from a myofunctional therapist that was at a major conference in California on sleep, and she said that the physicians there were saying that the difference between the rule A and B is just 3% versus 4% oxygen drop. And she was telling him, no, it has to do with an arousal. You don't have to have any drop. And they told her she's wrong. Well, they're wrong. They don't know the rule. And a lot of physicians are wrong. So if you're sending your patients to a sleep lab that doesn't understand, you may very well be getting back a study that's going to be falsely normal. And then you're going to think that maybe you're going down the wrong direction. Now, you've got to look at how that lab is doing their studies. And we're getting patients from around the country that are not getting proper diagnosis elsewhere. And we're looking more meticulously, and we're finding these patients have obstructive breathing, not surprisingly so, because clinically their findings suggest that they would have obstructive breathing. But there's a spectrum here that I want you to understand, with complete sleep apnea over here, normal breathing over here, and a lot of things in between. And when you're bruxing and clenching, you may be taking someone that would have been over on this end of the spectrum, and you're now protecting their airway with the bruxing process, and it's going to open up their airway. And so they may be having a less degree of obstructive breathing. When you're on this end of the spectrum, it has more of a cardiovascular effect. When you're on this end of the spectrum, it can fragment your sleep, leaving you with conditions that are going to cause symptoms, all right? And there's something called the upper airway resistance syndrome. And that is where the condition does not meet the definition of hypopnea, but it still fragments sleep to where there are symptoms. Now, the first article that came out on upper airway resistance syndrome using this condition by its name in the title was in 1992. And this condition was recognized and was characterized by Christian Guilleminot, who was my mentor at Stanford University. I was at Stanford. That's where I did my training in sleep medicine. Well, I was fortunate enough to be at Stanford back in 1992, and I was a co-author on this article. So this is like the first article that actually mentions upper airway resistance syndrome in the title. It was mentioned previously a few years prior to that in articles, but the thing is, what is upper airway resistance syndrome? It's changed its definition over time, and I'll talk about that here in a second. Okay, but this is an example of a patient that may have upper airway resistance syndrome. This is a patient that had a sleep study somewhere else and that came back negative. She had chronic fatigue, but she also had sleep bruxism. She's got a high arch palate, a narrow face, micrognathic, wakes up with nasal congestion, and she's the kind of patient that I think we're talking about a lot tonight. So we did the study. We added this extra nasal little catheter to measure the negative pressure in our airway, and we were able to establish the upper airway resistance syndrome. So the upper airway resistance syndrome prior to 2013 might start over here, okay? But then, and I'll be all of these patients, but now that you have the 1A rule, you can call these patients sleep apnea patients. So now it's over here. So these respiratory effort related arousals have not been really well redefined once they came out with the new hypopnea rule. But basically a respiratory effort related arousal would be a respiratory event that causes an arousal that does not meet the definition of hypopnea. So the cutoff was over here, but now it's down here. But there's, again, this spectrum. And again, if you're on this end of the spectrum, you're going to have more cardiac disease. When you're on this end of the spectrum, your heart may be fine, but you may have a lot of symptoms, just daytime sleepiness and fatigue, or sleep bruxism, and you're waking up with morning headaches because you're grinding and clenching all night long to protect your airway. Now, when it comes to sleep testing, home sleep testing has a good role over here because that's probably all you need in order to make the diagnosis. But as you start going down on this end of the spectrum, your home tests become less and less useful, because you're not going to be able to characterize the problem when the patient has a condition that's over here. So maybe they're going to have to come in for an in-lab sleep study. Or maybe you have to add this extra parameter of a catheter down their nose to measure their pleural pressure, their esophageal pressure, in order to characterize the effort-related arousals. So not all sleep studies are created equal. You are getting involved in this field. You need to know that. You need to learn more so you can do more, and that way you can take care of your patients more effectively. Now, there is a lot of literature on sleep bruxism, and a lot of it's going to talk about this rhythmic mascatory movement, okay, this rhythmic mascatory muscle activity, RMMA. Okay, Dr. Levine, who's done a lot of work and published extensively, this is what he's talking about. And it's an arousal. He defines bruxism by this. He doesn't talk about tonic bruxism. He talks about this rhythmic activity as being the bruxing process. So a lot of his literature is skewed because he's already changed his definition. It's not including in all instances of bruxism. And the thing is that this is part of the arousal. We see this all the time, but this doesn't explain everything, all right? But what he does say is that there seems to be a slight arousal that occurs right beforehand. And why is that arousal occurring? Because of the increased negative pressure. So here I'm going to show you in one of our sleep tracings, there's that rhythmic activity. And here's the increase in the effort that leads to that precedes it. It is here also right here, but the studies that these publishes, he's not able to get this parameter of the pleural pressure. So he's sort of blinded to not be able to identify this, but he's right that this phenomena does occur and it is related to sleep apnea, but this doesn't explain the whole picture. Anyhow, I just want to tell you that there's a lot of ways to collaborate, and I really try to encourage collaboration with and physicians and dentists can work together to meet a common goal in treating patients and taking care of their difficulties that they're having with their sleep and their health in general. I mentioned about the course. Do a screenshot here. Look at this QR code. Take a picture of it. You can register now for our conference. It's going to be in April 4th to April 6th. It's in Houston. It's going to be up to 24 hours of CE credits for dentists. Right now we have our early bird discount. Normally it's $18.99 for the 3-day course. It's now $14.99. And if you're a non-dentist, there's also a discount now. The first day is hands-on. You're going to work with appliances. You're going to learn how to do oral exams. The second 2 days, our physicians will be there also, but not all three. They're only there the second and third day, but you're going to learn about insomnia, narcolepsy, restless leg syndrome, other things that are going on in your patients that you're getting a history from. But you're going to learn about surgical ways of managing this orthodontically, through surgery, through oral appliances, and through positive airway pressure and the combination of the above, because a lot of times it takes a combination. Then you might also be interested in that you get a little humored by watching this TED Talk I did that talks about how a small mandible can lead to multiple problems. It's called The Neurologic Consequences of a Misfit Mouth on Sleep. And there's a lot of pathology described here in 16 minutes on this TED Talk. But anyhow, that concludes what I had planned to talk about. Thank you.
Whoa. Wow. Well, I think we all have to go to your sleep symposium to learn what you just presented in a record like 40 minutes. Thank you so much for that. That was very informative. I'm going to open up, actually, I'm going to open up questions on the panel. I'm just wondering if Ben or Michael, do you have, and Jerry, do you have questions for each other? Because you all heard each other's talks. And I know that Ben, you kind of stalk Jerry whenever you can. So I'm going to give you the opportunity here.
Ben's great. Ben's great. When I started going to these Airway conferences, Ben was the guy that, like he would just, if he could talk to me for 5 minutes, it'd turn out to be 30.
Yeah, it was border. Yeah, some people call it questioning you and others call it kidnapping you. It was borderline where that landed, but I just couldn't get enough. I've asked enough questions of these two. I've followed them for a long time. Let the audience ask away. Yeah.
Okay, great. Well, there are some questions on the chat here. So let's start with that for the people who are in the audience. Dr. Simmons, what would be an explanation for someone who gets adequate REM sleep but continually gets inadequate low deep sleep?
Well, many reasons. And so first I would question, how do you know it's adequate? Are we using one night in a sleep lab? You can't use that to know what the ongoing sleep architecture is for an individual, because when you're in a sleep lab, it's an unusual scenario. But a non-REM sleep can have a lot of abnormalities associated with it. There can be alpha wave intrusions, fibromyalgia can be associated with poor slow wave sleep, but yet you still need to get your REM sleep, so you may go into REM sleep. And so one condition might be restless leg syndrome with periodic leg movements of sleep. Periodic leg movements of sleep is typically not occurring during REM sleep when the muscles are paralyzed, but it occurs in non-REM sleep. So you can be getting arousals from those leg twitching movements, and that can hinder slow wave sleep. But I would still go back right away to say, what's the validity of the data to make that statement? Someone that's getting adequate REM sleep, how do you know? And that the REM sleep is adequate and their slow wave sleep is not? That's my first question to that scenario. But
Dr. Gaudio, Jerry, can a compromised nasal valve trigger the sympathetic nervous system response due to airflow resistance and/or flow limitation?
Well, yes. So as you're not getting enough air, you're going to get an increased sympathetic output. your body is measuring the difficulty. And so it's increasing sympathetic tone, and you might even be getting arousals because of the obstruction that's occurring. And so your nasal passages are extremely important to be patent, and everything follows after that. So if your nose is compromised, then you're going to have that negative pressure is going to continue through the rest of the upper airway. But you don't have to have a compromised nasal passage, as you know, to have a compromised upper airway. You can have mandibular problems, and your nose can be completely patent. But so the question is, can your nasal valve dysfunction trigger sympathetic output? Yes, if it's to the point where it's really hindering your overall respiratory capability. And that's really what it comes down to. So it doesn't really matter where that obstruction is occurring. But a lot of times you can have one nostril pretty well occluded and you still breathe fine through the other side. But there's normally a fluctuation that occurs, that you're switching sides throughout the night. So maybe when you're when you're trying to breathe out of the compromised side as your primary side for a period of time, that may be when you're having more difficulty.
All your opinions on lip taping. Dr. Gelb, I'm going to start with you. If you want to come off of mute. You can just come off of mute. Thank you.
We're big advocates of lip taping. Anything we can do to enhance nasal breathing and ensure nasal breathing. I find it, patients feel more refreshed in the morning. The scores are improved on follow-up sleep testing. So it seems to work well.
Ben?
Yeah, also good. It's on the list of things you can do. I love to combine it with nasal hygiene. Make sure you keep that nose clean and empty. Get the air flowing through there. And there's nothing wrong with the lip taping. In the younger of the kids, I prefer to make a little more room for the tongue first. Some of them come in really tiny, so I'd like to get through some expansion, get the nose going a little bit. Then you can introduce that. I usually don't do it in the kids too early, a little bit later. Yeah.
And Dr. Simmons.
All right. So lip taping is something I've learned from my dental colleagues. They've taught me. I was extremely apprehensive about the whole concept. Most of my physician colleagues right now are very apprehensive. We have a study group located in the north part of Houston, near one of my offices. And I remember one time this ENT doctor thought it was actual child abuse to lip tape. And she just was just totally emotional about how crazy this is. There's no good data. I think the literature is somewhat limited, which is unfortunate. There needs to be more good literature on lip taping. I think that it's not a cure-all. It's just one piece of the puzzle. Myofunctional therapy is clearly something that helps the upper airway function better. But most patients are not going to be treated with myofunctional therapy alone, but yet it will enhance outcomes regardless of what other treatment modality we're implementing. Lip taping, again, it's going to help with maintaining closure of the mouth. Obviously, it helps retain the mandible up, and it's opening up the back of the airway. Once you open up and you break lip seal and your jaw falls down, again, your mandible is going to more likely to become retracted. So you're getting some degree lip taping. One of the things we do for patients with sleep apnea that are on CPAP, we add a chin strap whenever we have the oral pressure leakage occurring. So in some patients now, we're lip taping instead of using a chin strap, but that you're going to get lift from the taping. So it's helping in not just maintaining seal, it also helps with position of the mandible. So it's something that I wish would get more focused research. And I think that one of the concerns is if someone were to have, let's say, an emesis, and they were to bring up and regurgitate, then would they end up aspirating? And so is there a liability that can occur? Someone with lip taping, and then they end up aspirating and get a pneumonia, or they suffocate and die. Now, I'm not sure of any cases where that's been reported, but that's what the physicians are going to think about right away. So when you lip tape, I don't think you want to do a complete seal, that you want to have some kind of escape if necessary. But so you're getting not just the seal itself, though, you're also getting lift, and that's an important point to be made. But don't try to completely cure someone with the lip taping process alone. Even if you're going to get a frenulum release, you're going to do myofunctional therapy, and you're going to lip tape. You need to do other things, whether it's appliance therapy or positive airway pressure. PAP therapy is not the enemy. All right. Now, when you're talking about long-term management, orthodontics, surgery, there are things that can be done to try to resolve the necessity of needing the mask in the machine. And there's other things that are out now. INAP, it's something that we don't yet fully understand how well that can work, but it creates a negative pressure to bring things forward. So,
And this one's for you. Do patients see a myofunctional therapist prior to coming to you, or before getting an Airvada device? So that'll be for you, Michael. Where does myofunctional therapy fit in with your treatment protocols?
Well, there's some people,
Yours.
no, there's a lot of people that do myofunctional therapy, one, to become nasal breathers. So there's a lot of people like Guilleminot that think the number one goal is to be have a child become a nasal breather. And I'm a big advocate of that. I think if a child does not become a nasal breather, I think Ben would agree, the orthodontics will fail. And there have been studies with Guilleminot out of Stanford. If you do paddle expansion, if you do tonsil, adenotonsillectomy, paddle expansion, but in the kids that need myofunctional, if you leave that part out, there will be relapse. So I think we'd like to see a child have their tongue habit controlled, anterior tongue thrust controlled, really airway, if you can. And that's why Ben says he likes to do expansion sometimes first, but you also have to be treating or teaching proper rest oral posture, establishing tone, because kids have all types of issues with, low tone. So it's got to be done at the same time, Lauren, or before, I think, orthodontic treatment.
Then you want to chime in on that?
Yeah, so agree. And there's no bad time to do it. There's no wrong time to be with a myofunctional therapist and working any of this. So whether you do it before, during, or after, the point is, get it done. Do I have a preference? Yeah, in the childhood population, they're so underdeveloped and there's no room in there at all. So I prefer to get the expansion going, meaning let's make the garage really big, then we'll learn how to park the car in it. So I tend to send them next. But it's not a problem if they've been to the myofunctional therapist, come in to see me, I could do my expanders, they can go back to the myofunctional therapist. We could do it in any combination. The important part is it needs to be done, because when that child is so underdeveloped, and whether they have a tongue tie or not, the tongue is going to be dysfunctional. It's how we got where we are. Just giving the tongue the home doesn't solve the problem. It's only one piece of the puzzle. That tongue has to be introduced to its new home, but it also involves all of the other muscles of the head and neck to deliver the nasal breathing, all of the proper muscle function and strength, as well as the posture. So yeah, my preference would be get expansion done, then turn them loose. But again, it wouldn't matter what order, just any order, as long as the myofunctional therapy is being done. Like Michael said, if you're going into braces without myofunctional therapy, you're going to have relapse near 100%. Just imagine coming out of braces at 15 and all you had was braces. You don't wear your retainer. What's the rate of relapse? Incredibly high. It'd be, unheard of almost to meet a patient that had braces and their teeth never shifted after they didn't wear a retainer, right? So the whole point is, if you're not going to balance the musculature and get the breathing and all that good stuff in place, you have no stability. And guess where the teeth are going? Back where they were, crowded. Everything falls back in towards the tongue. So if I had to choose, a child would be better off having myofunctional therapy early than braces late. So myofunctional therapy early, that has a benefit to that child that's lifelong, whereas braces late, 12 to 15 is what I'm saying. Braces at 12 to 15, really the only thing you get is temporarily straight teeth. That's about all it has to offer today. So you're better off having myofunctional therapy early.
Dr. Simmons, are you recommending 3 to 5 continuous nights for home sleep studies? And are there any home sleep study units you prefer more than others?
So yeah, one night is not necessarily going to give you the answer that you're looking for. If it's positive, that's fine. The thing is, there is a lot of night-to-night variability. So if you have a negative study, then you clearly may want to do more than one night. But let's say someone did 3 nights. Let's say someone did 7 nights. Let's say someone did 2 weeks, and every night is normal. I don't care which device. You're not going to get an answer from me saying this is the device, because I'm going to be contaminating people's perspective. The point here is that home studies cannot rule out obstructive sleep apnea. Cannot take that message home with you. If you're watching this, you're there, you need to know that home studies are limited. Now, if you can establish a diagnosis, that's great. But if you have a clinical suspicion that someone has obstructive breathing during sleep and your home study comes back negative, you've not ruled out the condition. You need a sleep lab that's using the 1A criteria that really does look for arousals, and you're looking for subtle changes in breathing that would trigger these arousals. And if you don't find that, okay, then it's a negative study. But you need, so I hesitate to answer and say this is the device that I think people should be getting. Pretty much all of the home studies are relying on oximetry. You give less parameters. And when you start talking about respiratory effort related arousals and identifying those on the home studies, it's really tricky business. You shouldn't be doing it, because arousals that are going to cause heart rate fluctuations can be picked up by some of these devices, but they're not necessarily respiratory. All right. And yet the company that's selling it and might have FDA approval for apnea under their apnea hypopnea index, they didn't present to the FDA the respiratory effort related arousals. They're throwing that parameter in there, and it could be pain that's causing the arousals. It could be periodic leg movements of sleep that's causing the arousals. It could be other things causing the arousals, and yet the report is going to say respiratory effort related arousals. So the apnea hypopnea index is much more robust on those devices, and you could rely on that. But if you're don't sit there and try to titrate someone's dental appliance because they have increased RDI, but their AHI is normal, because you may be titrating to something, you may be causing arousals from the pain from the appliance. So
Thank you. Michael, after you see new TMD patients, when is it safe to start clear aligner therapy when the joints are not that bad?
You want to resolve their chief complaints first. Also, so you want to, it takes usually minimal 6 weeks. You want to resolve the clicking, the popping. Ben did a very good job. The other thing is, and I don't know, I think Ben used it, but I was able to set up a position. So I do the work and I test the position, usually bringing the jaw down and forward. You see, and Ben has shown other cases that we've done together where I actually cause a posterior open bite. I'm not intentionally trying to do that, but the upper and lower really don't fit together. When I bring the mandible, the lower jaw, into the correct position, because the maxilla, the criminal, is not able to accept the victim, you get a mismatch. And so where I get rid of the clicking, the popping, the headaches, the neck pain, the tinnitus, the fullness, they then have a malocclusion. So one of the bad raps that we get is, well, you always change the bite. And I'm, more careful about that. So if I get rid of the symptoms and I set up the jaw position, they're in a perfect position to see Ben and start clear aligner therapy, or if he wants to do expansion, depending on how much they need. I'd say minimal 6 weeks, and I like to have them be asymptomatic for about 2 months, just to make sure that we're on solid ground.
Thank you. Dr. Miraglia, for class 2 retromandibular, child and adult, what appliance recommend to improve the mandibular, the mandible?
So class 2, yeah, when I hear class 2, I think narrow immediately. And so when I hear class 2, the maxilla is usually extra narrow, and that means the lower is trapped extra far back. So class 2, when you have that excessive overjet, both jaws are really reclined or retruded, retrognathic. So even the class 2 with severe overjet, the maxilla is usually too far back. So the immediate first step is expansion. And so The sagittal problem is usually secondary to the transverse issue. So when you have someone who has a significant sagittal discrepancy, it usually is being that the sagittal is the victim of the criminal being the transverse. So the more narrow you are, the worse your sagittal appearance might be. So the moment you start to develop the width, and it all begins with the upper, you have to develop the upper width and have the lower follow it. When you solve the transverse issue, a lot of times the sagittal will resolve itself because it was caused by the transverse issue. So immediately when you have underdeveloped jaws, you're going for the transverse dimension. And so what we do is we measure it intentionally between age 4 and above, because we have Dr. Bogue's research, which is 100 years old. I got introduced to this by Dr. Kevin Boyd. And so with Dr. Bogue's research early, he knew that you needed really to be at 30 millimeters by 4 between A and J. But then if you track that through Dr. McNamara's at Michigan, age 8, age 12, you start getting the 35, 40 numbers for good occlusion, where you should be. And of course, even in Dr. McNamara's research, it shows that the more narrow the patient is, the more trapped back the lower jaw would be. So you're looking for a solution in the transverse, because if you solve the transverse, you now have solved what is really a causative agent in your underdeveloped jaw structure to then have the opportunity for the sagittal to almost self-correct. Whereas if you only go after the sagittal, you can't make an improvement in the transverse. So treating sagittally offers zero benefit to transverse. You're going to have the same width. But if you treat transverse, you will have an effect on the sagittal, including the maxilla. Lateral expansion of the maxilla, or transverse lateral only, delivers a point traveling forward. And so that was shown very nicely again through Dr. McNamara and the University of Michigan, that just doing lateral expansion alone, a point travels forward. So you get wider and forward from the upper expansion, and the lower obviously delivers wider and forward from the release, thanks to the upper width. So I'm a big fan of transverse diagnostics and transverse treatment. And then you have opportunities to treat the rest of it secondarily.
Thank you. Dr. Simmons, can linea alba be a sign of negative pressure?
But again,
Can linea alba be a sign of negative pressure?
well, not necessarily from the pressure itself, but just other changes that are taking place in the mouth. So you're, bruxing, clenching, that may be in response to the negative pressure. So it's not a direct negative pressure phenomena.
Okay. Well, thank you so much for coming on. I'm going to give just some other announcements here. There were a lot of questions. Howie, feel free to stay on with us. We're actually going to do a raffle. So maybe you'll win. But I just want to start from the beginning here. Because we do have our Airway Health Meetup Facebook group. This is open to everybody, so please consider joining us. We do share a lot of information here with you and our colleagues, and also some parent information. So please look for us on that Facebook group. We'd love for you to be part of that. We do have our Airway Dentist Locator. There's a lot more green dots now, and it's becoming more global. A lot of people are asking me on a daily basis where they can find an airway dentist. So once you take one of our mini residencies, then you are able to be on our locator, and you will get patients. A lot of from your colleagues, a lot of doctors want to refer patients who move or loved ones, so you will get referrals from that, and we do have that global presence as well. We have our mini residency. This is basically our baseline course that we have for the adults and for pediatric dentition. Our next course is November 10th for the adult mini residency, where we show Dr. Miraglia's trued and tried techniques that he showed today. A lot of the questions were, how does Dr. Miraglia do this? What does he use? And we can't do that in half an hour. So that's why we built a mini residency to teach you exactly step by step how you can integrate this into your office. So we offer these throughout the year. They are available on demand as well, so you can reach out to me. Ben, I'm going to have you actually talk about our 2-day advanced course that's coming up, because it is about brackets and wires in an expansive manner. So I just want you to clarify the difference of your techniques versus maybe the traditional orthodontic techniques in your 2-day advanced course coming up.
Yeah, the 2-day advanced course builds off of the pediatric mini residency. In the pediatric mini residency, we teach the attendee, the doctor, how to treat anything from age 3 to 12. But then you do have kids who are 13 to 19. So in the 13 to 19-year-old range, it is perfectly acceptable and appropriate to use expansion, and we do fixed expanders in that age range. It just happens to be a slightly different technique. So we teach in that course, the advanced course, how to use fixed expanders between 13 and 19. And so that probably ties into another myth that you can't expand after 12. I've been doing that for 20 years now. And 13 to 19, you can expand at any age, really. But the fixed expander technique is taught from 13 to 19. And we do teach an expansive bracket and wire technique, but it's never alone. In other words, no patient gets braces alone, because braces are about the teeth. So when we teach in this advanced course, we teach foundational growth first. So you learn how to use expanders between 13 and 19. You grow the foundation first, then you're permitted to align the teeth. You can align the teeth with clear aligners or braces, provided you have a full foundation. So we do teach a beautiful expansive technique, foundation first, teeth second. And again, the only appropriate time to use brackets and wires would be after you've had full foundational development, nasal breathing, frenulums released, myofunctional therapy. All of those things are in place. Then you can use the braces to straighten the teeth. That's how you have stability at the end of everything. So that would be to clarify, the only time that braces are appropriate would be after all of the collaborative care and foundational growth is first. You could use braces dead last to make teeth straight. But to use braces alone between 12 and 14, really a near useless technique. One other myth I could add there, the one other myth I was going to get to, just short and simple, is that the myth would be that it's okay and it's not a bad technique to extract teeth. And that's a total myth, that it's okay or appropriate or needed to extract teeth. Total myth at any age. No human being needs an extraction, not 1, not 4, not 3, not 2. There's no such thing as needing an extraction. And there's no such thing as that's a good technique or justifiable anymore. You don't need less teeth, you need more. We need to get to 32. We need to get back to having a full foundation and have 32. That's what a full human being is. That's how a human being functions properly when you have all your parts. You start taking parts away from something, it doesn't work the same. 4 wisdom teeth alone, those are 4 good parts that you needed in place to function perfectly at the whole jaw level. So we need to get back to 32 teeth. It's a myth that extracting teeth is okay in any direction. That's so wrong.
Right. Thank you. I'm glad we got that in there. Michael, let's talk about your course. I'm so excited about this. So as you know, Airway Health Solutions and Airvada, we partnered together because you evolved as the appliances evolved. So it didn't make sense anymore to not teach what you were not doing, we need to teach what you're doing. So as you evolved, the course is evolving, our partnership is evolving. So why don't you tell us about a little bit about the course that's coming up on October 20th?
Yeah, so we go into more depth. We talk about diagnosis. We talk about cone beam, home sleep testing, taking the bite, and how we set the case up for orthodontics. We get rid of all the symptoms and then set the case up for everyone that Ben is teaching to be able to go and permanently to stabilize the occlusion to an airway-friendly, airway-centric state, as well as a TMJ healthy state.
Wonderful. And we're offering shadowing opportunity because we thought that was important to have the hands-on component. So if you reach out to me or go to the website, you can see how you can have that in-off shadowing, which is offered at half price once you take the mini residency. So you get to spend a full day in New York City. I'll pop in too, because it's always nice to see you and your team. They're wonderful, right by Grand Central Station. So reach out to me and we can talk a little bit more about that. And I know Kevin was on earlier, as he likes to be called, Kev, or the infamous Dr. Kevin Boyd. He has an amazing course. Dr. Miraglia is also part of that. That's now available on demand, because we've had a demand for on demand. So we are making this course on demand, but we do like the hands-on component. So we are offering the half price in-office shadowing as well. So reach out to me. We'd love to tell you, he fixes under 6. Fix under 6 is the theme, and he'll teach you his techniques as well as behavioral management for the children. So it's a wonderful course, and it's going to be ongoing with updates. So you'll always have the latest information once you're part of our alumni. We love our Team Myo courses. There's one that just started October 4th, but it's not too late. You can catch up and we can give you the first recording of our Monday meetings. But take a look at this menu. I'm going to just save some time, and just if you have any questions, reach out to me, Brittany, Sierra, or Carice Laguerre, and we'd love to help you out there. We have our Airway Palooza coming up. I actually just came back from New Orleans. I did a site visit. I had to make sure that the room was good, the food was good, the drinks was good. It's all good. We're ready to go. We're going to have a wonderful, wonderful time. You can see these speakers. It's unbelievable that we're all going to be together under one roof. We just added Dr. Dave McCarty. I'm really excited with the empowered sleep apnea. He's going to be one of our speakers as well. But I just look at this lineup here, and everyone is going to share with you pearls, just like tonight. You're going to walk away with so much information. And the good news is you get to talk to them throughout the conference. We have everything included. I love everything included. So all the meals are included, the drinks are included, the music is included, the socials are included. So check that out. There are specials going on, but you'll see that in the follow-up email. I'm happy to be on the board of the Children's Airway First Foundation. I know we have multiple board members. Dr. Simmons is actually on the board, as well as Dr. Kevin Boyd. We're doing wonderful work together to share the message to parents. So when your parents have questions, have them go to the Children's Airway First Foundation. Actually, the Foundation for Airway Health is listed there. All of the charities are listed under one website, so you may want to go ahead and check out the resources. They have wonderful podcasts and information for your parents. We're going to hold the first ever, I believe, Parents Town Hall. So this is going to be Wednesday, November 8th. Mark your calendars. We'll send the link to you via email to invite your patients to come and ask Dr. Ben questions. So this is a really wonderful opportunity for you. We're going to archive this. It'll be available on YouTube, so you can have this in your library, in your educational library, for parents to watch. So we're really excited and hope we get a good turnout. So please share with your patients and help let us help, help us help you. We went through this, so that's wonderful. We do have our quarterly town hall meeting. It's starting late because all of our alumni is on with us, but that is an exclusive perk that we offer quarterly with one of the faculty members. It's usually Dr. Ben or Dr. Gelb, Dr. Boyd, very generous with their time. It's almost like office hours. So once you take one of our courses, you're able to ask your questions at no fee quarterly. So that's just another perk, and we're going to jump over to that soon. But before we do that, we do have a raffle to do. So I'm going to stop my share, and Jerald, my director, is going to go ahead and we're going to spin the wheel. And oh, Dr. Simmons, yes, can you come off before we spin? Can you come off and tell us a little bit more about the SEC? You're on mute. You're on the mute. Yeah, one more time.
Yep, it's coming up in April 4th through 6th. I showed the QR code in my talk. If you don't, the webpage is really easy, dentalsleepconference.com. And you can register right now. You can avail of the early bird registration rate, which is a significant discount for the dentists. 3-day course. You're going to learn a lot on sleep. I mean, everyone that's attended, it's been a mind boggler. It's been a transforming process for a lot of dentists where it's changed their practice.
Wonderful. And we'll send that information out in the follow-up email too. So if they miss the QR code, they'll have it in the follow-up email. But before we spin the wheel, I just wanted to thank you all so much, the speakers. Thank you, Howie, for joining us. We can't express our gratitude enough. The lives you've changed my life for good, just by able to spread the word. You sleep so well at night, knowing that you're actually helping children and parents and patients breathe, sleep, and thrive. And we couldn't do it without experts, pioneers like you, who've learned from other pioneers who just pay it forward. And you guys do an amazing job at paying it forward. So we really applaud you for that. So thank you. And we'll keep doing these master classes, as I said, because we need everybody to know this, and there should be no barriers. So we're going to break down barriers, and we're not going to have any barriers, so everyone can learn. And we applaud everyone for being here tonight, your commitment of time and health for your patients. So let's go ahead and spin that wheel and see who wins the free Airway Palooza live ticket. You have to be in attendance. So, all right, Joe, let's spin it. Tammy Ray, let's see. I have to scroll. Let me just, I'll lose this. Let's see, go all the way down. I can't believe how many people we have. You guys are great. Tammy Ray, you're our winner. Yay. Okay. Thank you, everyone. We had a wonderful night. It was wonderful spending time with you. We'll send you follow-up emails with all the information you need. And we're here for you. And support all of these charities because they support you. Thanks, everyone. Thanks, panelists. Wonderful, wonderful evening. Thank you.
Thank you, Lauren.
Thank
Thank
you.
Thank you, everybody. Great to see everybody.
Bye-bye.
You. Take care.